Oh, this is a special lecture by Dr. Gokhale from Yashoda Hospital. Cardiac support in advanced heart failure, overview of current device in the future.
Say good afternoon, everyone. Dear Dr. Subramaniam and colleagues and friends. See, rarely we get to give a lecture in any meeting in time. In fact, I was pleasantly surprised when I was asked to talk beforehand. I had a cup of tea, I had to discard it. But at least back here in the right time. See, this is a very interesting area. Cardiac surgery has been advancing, but there are problems we are facing as surgeons because of the technological developments happening in the physician side. And many a time, surgeons who keep saying that what is right is not being done. But one thing we have to remember is there are a lot of areas there are a lot of lacunae in the treatment of these cardiac patients, and we need to look at those areas and then work harder because there is enough for everyone in the world. Now, this is one such area. Today, I am going to talk about overview of current ventricular assist device and the future. Very, very interesting area. And I would like to thank the organizers for giving this topic, which is a topic for tomorrow, but we have to start learning from today in India. Now, you see, as usual, we do not have any statistics for many things in our country, but he said approximately there are about 50,000 patients in this country who would benefit from heart transplantation. The number is equal to the number of patients waiting for kidney transplants. We all know about kidney transplants, liver transplants. The same number of patients are available in this country, but somehow it has not caught up with the imagination of the physicians as well as the patients. But if you look at the impact of heart failure in America, you look at 5 million plus Americans with severe heart failure and nearly 7 lakh patients being added every year. Of these, 280,000 patients die of heart failure in the US every year, and this produces the second highest mortality. Now, if you look at the natural history of heart failure, see, stage 1, 2 is fine, but the moment they enter the stage 3, see, the deterioration starts, the mortality starts going up, and the survival comes down. About 25% of cases of heart failure are in the stage class 3, and they require frequent hospitalization, worsening symptoms, and there is a significant opportunity to do things because we know the cardiac diseases are becoming rampant in our country, and even today, I cannot find many cardiologists who are interested in the heart failure management. This is a golden opportunity for surgeons to look at it and take care of these patients because there is a huge population. Even if all the cardiac surgeons and the cardiac physicians can get together, the way that diabetes and hypertension are increasing, there is enough and more for everyone, and we need to look at this seriously. Now, once there is advanced heart failure, what are the options available? One is optimal medical therapy. This is becoming, of course, this is the most important thing in the management of heart failure. 80-90% of people can be managed to live longer with the quality of life. But unfortunately, there are a lot of lacunae in this because not many people are interested. And the second one, when the medical treatment is not adequate, look at the electrophysiological testing and then use devices like prophylactic ICD placement or resynchronization therapy. Then, of course, this helps only a small percentage of the people. Still, there are a lot of people who are not being helped by medicines or by resynchronization therapy. What are the options we have? Now, the golden standard in these patients is heart transplantation. However, there are a few limitations. See, for example, in the world, there are about 30,000 people who require heart transplant, apart from countries like India, etc. You are talking of developed countries. But there are only about 3,500 heart transplants are being done per year because there are not enough number of hearts available. So even if someone wants to go to transplant, there are a lot of people who cannot get a heart. And the second thing is, still there is a huge proportion of people with heart failure who are not fit to undergo heart transplantation because of many other reasons. So that means there is a big chunk of heart failure patients, severe heart failure, not responding to any of the medical management or resynchronization therapy, and where transplantation facility is not available, and what to do with these people. Now, if you look at the historical events in the development of managing this heart surgery or management, see, it all started in 1953 with Gibbon inventing the heart-lung machine and closing the first ASD in the open heart surgery. After that, in fact, if you look at 1963, DeBakey implanted first ventricular assist device, and after that, 67, Bernard performed the first heart transplant. So the assist device actually, they started even before heart transplantation. Then, of course, somewhere did the transplant, then Cooley put the ventricular assist device. So that's how slowly assist devices have improved. And now, in the last 10 years, all over the world, assist devices have started picking up very fast. What is the reason? Assist devices have been there for a long time. Heart failure has been there for a long time. There are two trials that have come. One is rematch trial. This came in 2001, in fact, and after that the assist devices have picked up. The real pickup has come from 2009 when another very important landmark paper was published regarding the continuous flow versus pulsatile flow. That study showed remarkable improvement in the working of these assist device. What is this rematch trial? The randomized evaluation of mechanical assistance for the treatment of congestive heart failure. In this, optimal medical therapy versus the first generation of assist device, that is a pulsatile flow. And this was HeartMate XVE was used, and they have taken about 129 patients with a severe LV dysfunction. And for their pleasant surprise, when they followed them for 1 to 2 years, they found that whoever had the assist device, the survival rate is at least twice to that of medical treatment. First time these people had something to look in the world for. So this has shown there is a remarkable survival rate, and they also found that they had a great quality of life. Then the doors have opened for the ventricular assist device. Now, other thing that has come was with the pulsatile assist device, by the end of 2 years, there are a lot of failure rate. But then that stopped there. It is costly, insurance companies were not allowing, and it's a huge bulky device they used to implant in the abdomen, and it used to weigh almost about 2 to 2.5 kilos. That stopped them there. But later, second generation of assist device, continuous flow device have come. Normal physiological circulation is pulsatile, but then the continuous flow they tried, because it's easy to manufacture devices for continuous flow. They can cost less. To see whether they work better than the pulsatile, this continuous flow publication has come. This has shown that if you look at this continuous flow and pulsatile flow, survival free from disabling stroke and reoperation to repair or replace assist device at 2 years. This is a primary composite endpoint. They found 46% of the people in the continuous flow were free from this from problems, whereas pulsatile flow only 11. So at the end of 2 years. So a lot of people here had a problem. This showed that there is a possibility that continuous flow can remarkably improve the results for these people. And the second thing they found was, here if you look at probability of survival, they found that the continuous flow, the probability of survival of the patients at the end of 2 years is much more better, almost twice compared to the pulsatile flows. And if you look at various problems with the bleeding, stroke, replacement, mechanical device failure, many things, they compared the relative risk with the continuous flow and pulsatile flow. They found that the continuous flow has certainly yielded much better results. So by that time, the second generation HeartMate 2 is available, and looking at these things, that these are the best device compared to the previous one, have shown a longer term better results, and freedom from failure of the device, then the assist device have really picked up in United States of America. What do we do with the ventricular assist device? It provides mechanical circulatory support to restore circulation of blood flow to the body, decrease preload, decrease cardiac workload, increase systemic circulation and tissue perfusion. Sometimes the kidney renal problems, pre-renal problems, and hepatic problems, they all get corrected, and decrease neurohormonal response. And of course, this can sometimes lead to recovery in some of the patients. What are the indications for use? There are 4 indications. One is bridge to bridge. Patient is in cardiogenic shock. And for example, right now in India, we have 2 devices. One is CentriMac, costs about 5.5 lakhs. The other one is HeartMate 2, works longer, very good, costs 60 lakhs. Now suddenly you have a patient there. I mean, you see, to put a HeartMate 2, we do not know what happens. It's a difficult decision. So you can use device like CentriMac, put it, make it as a bridge to bridge. You got time to think. Patient is all right. Okay, we'll take a 1 week, 10 days, no pressure on the attendants as well as the doctors. So then he can go for a bridge to HeartMate 2 if he is not fit for transplant, organ is not available, or if he has got organ is available, go for transplant. Otherwise, he is for destination therapy, then put it as a heart destination therapy. So it is a bridge to bridge for another device. The other one is a bridge to recovery. Sometimes it is an acute cardiogenic shock, which we will see later. In those patients, we think there is a possibility of myocardial recovery. I mean, there is one situation where I used it recently. Then you can use this device. The other one is bridge to transplant. Patient is sick, fit for transplant, heart is not available, which is very common. Then you put a device and keep the patient alive, make sure that all the organs are working. then do the transplant when it is available. The other one is, if the patient is not fit for transplant, then put the device as the final therapy. There is a destination therapy. This is where the assist device helps. Once there is an injury, decreased cardiac function, dilatation, there is ventricular remodeling starts with neurohumoral activation. And this can be stopped or reversed by cardiac support device. This is one area where the assist device helps. Now, what does the ventricular assist device at the end of the day? It definitely has shown improved survivals and improved quality of life. That's also very, very important. They could return to normal activities of daily living. They could live independently, patients. They could drive. They could go for work. They could go for holidays, which you will see later. Now, of course, what are the contraindications? That is, as a surgeon, especially as a surgeon, we need to know contraindications whenever we are doing a procedure before we do that. Someone who has a recent or evolving stroke, neurological deficits impairing the ability to manage the device, they should be able to manage the device. There should be no coexisting terminal condition. Suppose there is a huge aneurysm, it's a contraindication, active systemic infection, fixed pulmonary or portal hypertension, impending renal or hepatic failure, severe pulmonary dysfunction, or for example, most of these devices at this stage, we need to give them oral anticoagulants. And if they are not able to take them, these are not the people for whom we can go. We know contraindications, we know indications, but when do we have to put? See, when do we have to do a procedure? That is another major issue with us, because you do it yearly, it's a very costly procedure, and many a time with all the costly procedures, we try to delay it as far as possible, hoping that the nature will make the patient survive or the body will take care of it. And by the time we do all these costly procedures, most of the times we lose the patients because we do it late. And for this, there is what is called intermax, that is interagency. It collects all the data about mechanical assisted circulatory devices, and it has given us some criteria when to put an assist device in a particular category of people. There are few levels here. For example, level 1, crash and burn. Patient has come with a cardiogenic shock, post-MI, not coming off pump. There's no delay there. You have to do immediately within hours. The other one is patient condition is deteriorating fast in front of our eyes. Then you cannot wait for very long, days to weeks. And suppose reasonably stable but dependent, then you got some time to think. You can take a few weeks. And of course, people who come into the hospital, get better with the dobutamine or levosimendan, then go back, come back, go back. These people you got some time. And someone who is spending most of the times at home, but we know he has got advanced heart failure, finding it a little difficult, then you got some more time. That's how you decide. Because right now I have a patient who is waiting for transplant. I don't know. See, the heart is not available. Should I go ahead with the assist device because blood pressure is 100? He goes into the ICU every 3 days, keep them 2 days and come back. But if I put it, whether it go into the right ventricular failure, we are not very sure. It's a very confusing situation. This, except in emergencies, this will take time. Now, other thing we have to know is, it's not like that you put something in the pocket and go away. Ventricular assist device runs on electric power 24 hours a day, 365 days of the year. Patients may connect to a power-based unit to provide consistent power, or connect to a set of batteries which must be changed every few hours to maintain a reliable power source. Patients must be connected to power at all times, which can be a problem in places like Hyderabad. In the recent past, we find it, for example, 12 hours, 24 hours, there is no electricity. Now, there are so many types of assist device, but there are certain standard things. Everything should have an inflow, takes blood from the ventricle or the atrium. It has got a pump, it has got an outflow, it has got a drive line. This is the one through which power source comes. Or sometimes, you see, you interrogate the device, what it has done. Now, there are many types of assist device. You want to call it the left ventricular assist, right ventricular assist, biventricular, pulsatile or continuous, or you want to put in the body intracorporeal or extracorporeal. You want to open the chest, or you want to do it percutaneous, and you are going to use the assist device for a short term or for a very long term, or the assist device is going to produce, heart is very bad, you have to give the total support, or you want to give only partial support. This is a very exciting area, which you will see in the next few seconds. Basically, these are the generations in the development. First generation is pulsatile. This has gone out of the place now. Second generation is continuous flow. This is the HeartMate 2 that is available in India, being used most of the times. But there is one problem here in the continuous flow. In the machine, there is a propeller, and it propels the blood. But this propeller is connected at both ends to the box of the pump. So there are joints, bearings. When it rotates, there is a heat. The bearings get damaged. So there is a possibility, like in some cases, that there is a deterioration in the function of the pump. Now there is a very interesting area where there is a propeller inside, but it floats. It is not, there are bearingless, basically. It is magnetically levitated. There are two magnets, keep it floating in the middle, so it keeps rotating there, and the blood goes through that. There are no joints to get damaged, and there are no bearings which need replacement, so they work for a very, very long time. This is what is happening with some of the pumps. The Centrimag, which you used recently, is a levitated pump. There are no joints inside. Now, for example, this is another group which we are likely to face, most of the clinical situations, especially as surgeons. Chronic support, something comes from the cardiologist, but for us, this is the area, bridge to recovery, bridge to decision. The IABP is a common thing that we use, and ECMO is another thing that can be used. It costs about 1.5 to 2 lakhs, can be kept for 1 to 1.5 months. And we have tandem heart, Impella, percutaneous in the arena of cardiologists, Centrimag, Ebiomed, and these are other devices that are available. Intra-aortic pump, we all know, we have used many times, so we don't have to talk about it. ECMO we can use to stabilize the circulation, even though lungs are fine. It is the cheapest form of assist device that is available to us. And tandem hearts, this is a centrifugal pump. The cardiologist puts it from here into the left atrium. He puts a venous cannula through the septum into the left atrium, takes blood, and into the femoral artery is pumped. There is a centrifugal pump that is attached here. But the problem is, this is actually approved by FDA for only 4 hours. When they are doing a difficult angioplasty procedures, our patient has crashed, arrested, he put it until something else is done. But it can be used for a few days, couple of weeks. This is the pump that is available in India. Actually, it has come in a few months back. This is a magnetically levitated pump, centrifugal pump, continuous flow. It is extracorporeal, okay, and this can give you a flows of up to about 7 to 8 liters. And this is approved by FDA for use for 1 month. Of course, Dr. K.M. Cherian has used it for almost 50 days as a bridge to transplant. And if you look at this, the Impella device, okay, this has come into our country, has left unfortunately because not many people have used it. You put it through the aorta, part of it is inside the LV, part of it is in the aorta, so it sucks from here and pumps it there. And this also can be kept for a few hours. FDA has approved for 4 hours, and this is for useful, especially in emergency situations, as we discussed. Now, in some patients, especially acute situations, like cardiogenic shock, non-ischemic, especially like postpartum cardiomyopathy, dilated cardiomyopathy, some of these patients worsen, and those patients, the recovery chance is about 30 to 40% when you support with this. Fulminant myocarditis, post-cardiotomy shock, these are the places where it can help the reverse remodeling. Now, what are the parameters to predict recovery? I think there are a few issues here, somehow these are not recognizing. Then what they do is you do echocardiogram, especially once the patient goes out of the ICU, generally after 2 to 3 weeks, how the LV is working, what is the ejection fraction, what is the end diastolic volume, what is the end systolic volume. In some assist device, you can slow it down, totally hypernize, and then stop the circulation for a few minutes and watch it. So it's a difficult area again, lot of help from echo, we require it. For long-term device options, this is one that is available in our country, HeartMate 2. This has gone out of the work. This is a total artificial heart. And of course, this has again a pulse type flow that is not available. Right now, this is available and this is available. This one is in India, but this costs huge amount. When there is a biventricular failure, you take away the heart and stitch it there. Whereas this one is an addition to the existing heart. Now, this is how HeartMate 2 is there. Okay, you implant the LV apex. This pumps into the ascending aorta. Drive line is outside. Now, some complications we have to know again as surgeons that when you put this device, early things are bleeding, tamponade, arrhythmias, suction events, and around. It's a great experience. Unfortunate part is this Novocar was stopped produced from Australia, so the device is not available anymore. And if you look at Dr. Bala has some experience in this area. He put about 6 Berlin hearts, and 1 went to transplant, 2 had Centrimag put in. Of these 6, 1 went to transplant, 5 died. 2 had Centrimag put in, 1 died in the early post-op period. The second one is he did a transplant recently. Post-op patient had RV failure. So he put in ECMO and giving the support to the Centrimag. He told me that the patient is getting better. One was used in Gangaram Hospital. This was a bridge to recovery. This patient has got severe aortic stenosis, severe LV dysfunction, and moderate MR, and they did aortic valve replacement under the help of CentriMag. Patient did well. Frontier put one CentriMag. Dr. K.M. Cherian, as usual, the leader in most of the cardiac surgeries, put one CentriMag as a bridge to transplant. At the end of 55 days, this lady underwent transplant procedure, and Medanta Medicity put in one CentriMag as a bridge to transplant. Patient died, and we did one in the last month as CentriMag as a bridge to recovery in a patient with severe aortic stenosis and gradients of 35, ejection fraction of 20%, and ventilator, huge inotropes, and borderline pressures. And this is the patient. I want to show how much miracle these things can do in certain situations. We have to be aware of it. It's not always possible. This lady was diagnosed with aortic stenosis about 2 months back, had angioplasty about 5 months back. That time they said there is a mild aortic stenosis. Now 2 months back they said she has a severe calcific aortic stenosis, but LV function was around 40% that time. Gradients were around 60, and her TSH was 125. So we started increasing the thyroxine. We do not have IV preparations. Patient refused surgery. So she came to the hospital, went back like that for about few times. Then about 3 weeks back, she came in pulmonary edema, went on to the ventilator, and cardiologist balloon aortic valvotomy, no improvement. Ejection fraction was 22%, gradient was 30, and huge inotropes, blood pressure was 80, and I wouldn't have done the surgery for that lady with that situation at the end of 10 days. But then this device has come. We took her high risk, we did aortic valve replacement, put a pericardial valve, implant the device, and then she came off. This is the device. See, this is the device, centrifugal, magnetically levitated. This is a control device. And we gave a flow of about 2 to 2.5 liters. And you see, these are LA cannula that was taken through the percutaneous cannula that was put into the left atrium between the right and left superior pulmonary veins. And this aortic cannula that was brought in from the subxiphoid area. These are the ordinary cannula which we use. See, and these are LA cannula was there, aortic cannula was here. Of course, we have to fix them, then close the chest, and at the end, this is the thing. That time we were giving about 2.5 liters of support. And you can see the pipes, 2 pipes coming in from the body. On the right side is the inflow, and she was extubated after about 72 hours. And then after about 6 days, the flow started going down. This is the first device. We are not sure. We have to maintain it with the ACT of about 180. There are so many ifs and buts when we start. Patient echo showed that the LV is better now, around 35 to 40, and she's maintaining good urine output. All the subsystems were all right. So we took the decision to remove it. And after that, she has done well. She has gone home in day 5. In conclusion, ventricular assist devices are getting popular in improving the quality and the longevity of life for patients with severe heart failure. They are getting smaller with better long-term results. Can be thought of to provide partial support to less sicker patients to help the myocardium recovery. This is another gray zone. Some patient is there with the LV dysfunction, ejection fraction of 25%, reasonably okay, class 3, not too bad, but maybe in these patients if you put assist device, decrease the size of the LV, it will undergo regression, and sometimes these patients can be taken off and they can lead a normal life. This is another area that is being worked up. With increasing experience in future, it may be thought of as an option of choice compared to transplantation, even those where transplantation is indicated, because technology is getting better and better, and if an assist device can work very well with least complications, maybe we'll forget about transplantation in future. There is a possibility there in the horizon. Thank you very much.
Thank you, Gokhale, for excellent presentation of this devices for heart failure, and I thank you for giving the show on this Levitronics and its use, and any other indication you advise for this Levitronics?
See, now actually we have to look at things. So many times we keep some of our coronary patients, for example, and they are on inotropes. You see, actually there are a lot of algorithms that are developed abroad that someone with a ischemic problem also, we put in IABP and then we wait for some time. We all lose patients, even in IABP. Some of these patients, they have been living with the disease before. If we can provide adequate cardiac output in the post-op period, subsystems are working, and the perfusion is good, some of these patients are likely to live. Any patient in the cardiac surgery today, I think if we are having difficulty in spite of high inotropes, in spite of IABP, then we should think of it. This device is available. It costs 5.5 lakhs, I'm sure, but if we bargain, it will come down to 4 lakhs. And that is one very classical area. And second thing is, we can expand our horizon of surgeries. Forget about the days of good LV function. Now we got comorbid conditions, and in the immediate post-op, creatinine is 1.7, and the blood pressure is, say, about 70, 80. Naturally, we see creatinine go up to 3, 3.5, organ goes, then start dialysis, it's all a mess. These are the cases where we may have to think of assist device because it can support with less complications for a few days. And the other thing is severe LV dysfunction. And someone who has a severe LV dysfunction, they are walking around all right. Why do they die after surgery? Obviously something related to the myocardial perfusion or the technique of surgery. Many of us have become reasonably good. The Indian surgeons are excellent surgeons, but the myocardial protection can be a problem. So these severe LV dysfunctions, probably we should look at operating them. These are the challenges. These are the surgeries for the future for the surgeons, not anymore straightforward. Percutaneous aortic valves, percutaneous mitral valves, and multiple stents. But there are a group of severe LV dysfunctions, which I'm sure for some more time people don't touch, and that I think we can get more cases into our armamentarium. Not just transplantation, but that is something that is possible for us.
This is a question I also get when the patient is moving around, even with severe LV dysfunction, ejection fraction 20%, but after surgery the patient didn't do well.
Yeah.
So,
but this is a beautiful area where you can apply this.
This thing very good.
What force do you maintain and how long can you maintain?
Yeah. So okay, the CentriMag that is available now, as I said, two devices are CentriMag and HeartMate 2. CentriMag FDA approved for 1 month, but there are people who have been using for longer time. Now how much flows to go? The lowest you can put is 1000 revolutions. Anything goes because there are no valves in this. These are all centrifugal or axial flows. They do not have valves. The moment it is less than 1000, the aortic pressure will make sure the blood comes into the left atrium. There is a reversal. So you have to make sure it is at least more than 1000 revolutions. Now for 1000 revolutions, the flow will come around 2 liters in general for adult patients. Okay? So you have to adjust anything more than that. When you are weaning, you cannot reduce to less than 1000 revolutions. And the other thing we have to learn is, immediately after implantation, we reverse heparin just like any other patient. Once there is no bleeding, then of course you start a heparin infusion to keep ACT around 160 to 200. It's not huge. They require about 250 to 250 units, 300 units. That's how we maintained it.
What are the criteria to be in this center?
Yeah. See, the thing is, first, patient has to be fully conscious. All the subsystems must be working all right, like a urine output and everything. Blood pressure is good. But generally, once you put in, we better wait for a little longer unless the platelets are going down or some other bleeding problems are happening. So, and then you keep doing echo. We have done echo every day. And then you can, and other thing is, you cannot just keep the same flows. Suppose you give 3 liters flow. You maintain like that. LV is empty. There can be a thrombosis in the left ventricle. And they can develop RV dysfunction. Sometimes you have to increase the flows, decrease the flows, so to give a little work to the LV. It doesn't undergo atrophy, there is no thrombosis. So when you do these things, with the way the patient is progressing, then you will see it. Once you reduce the flows a little bit, generally after 4 days, 5 days, 1 week, you would get that gut feeling. Because why I'm saying is, right now there is no definite criteria for these things. I went in like Abmanya, put in that. Now when I want to get out, I didn't know. I had to call this person from America and then Salman who has supplied this. No one knows. Once you put in, you are on your own. So you have to play these things because in areas like this, no one teaches us. We have to go with caution, with over caution, let us say, and then we have to do it. And with all the gut, see, we all survived with the gut feeling in this country, not with the technology so far. So, like that.
Change is not the way to go.
Yeah, I guess. But I think we have to do one in India, just the way the TTK valve is there. Yeah, I think so. We have potential. Change is a problem, no? Because in life, it's very difficult, and these things probably will come for less. If the HeartMate 2 is 60 lakhs, because that is the one that is for, see, this is the only one that has been approved for destination therapy. Okay, and other thing destination approved is Abiomed. That is for destination therapy. It is a total artificial heart. So that's why there is no one else close to them. They have a huge experience. They're demanding once some more you get, they'll come down.
Maybe cardiac MRI might help us.
Sure, yeah, definitely we have to do what all you are doing, you do it. But then you see, you do MRI, you do thallium scans. One of the problems I find is LV dysfunction, you send it. There is no way of quantification. They say, we find there is a lot of viable myocardium in the anterolateral area, in the base, apex. What do you mean by a lot of myocardium? There are people who say it is a 25%. I mean, 25%, echoes. One says ejection fraction of 25%, the other guy says 50%. So all these things, we have to assess ourselves, and in sick patients, we can't go just by MRI. I would do MRI as nuclear scan, compare. If both of them correspond, then I would be more confident in handling them. Otherwise, we have to add a third test, dobutamine echo, and then see which will get. So I think we have to be choosy, but we shouldn't stop. In all these patients with severe LV dysfunctions, multiple problems, I think we have to be more aggressive, cautious, knowledgeable, but more aggressive approach we have to take.
Can you describe what happened the post-operative day when you decided to take it off? What was the patient like?
See, I tell you, there are two things there. It's an excellent question, which it is not scientific totally.
Because there were two statements that didn't make sense.
Which one?
The flows were coming down and the patient got better.
No, it is actually, patient got better. Flows are coming down, that means the machine is not doing great work. Patient got better because the heart is working well. That is a good sign. When without machine support, the patient is getting better, that means time to take it out. That is one. And the second hidden agenda behind that was, I was going out of station next 2 days, okay, and I have put in the device, I don't know what to do, and my colleagues were little jittery, patient was stable, and I am there for next 18 hours, and when things are looking, is this a time? Because, these are all a combined decision. When you do something new, gave about 2.75 flow, but now with 1,500, the flow has come down to around 1.5 to 2 liters. It may be two things, that maybe the cannula is not in position properly, maybe touching the mitral valve. The echo doesn't show, but how many of us have got experience to say exactly it is not touching mitral valve, things like that. And you see, there are many areas where we are dependent on other people. So that is one. Then you have to go take him back to readjust, or the second possibility is whether some clots are forming. I mean, you see, none of us, in India, you can't call someone and say, what do you think about this? Because there is no one to tell us, this is the way to go ahead. So we have to take our decision, and patient is creatinine normal, we extubated her, she looked good, and she had a gradient. I would put it this way, it is not that I went in like that. She had a gradient of around 70 about 3 months back. Anyone who had a gradient of 73 months back suddenly means the acute mechanical thing has added, some insult has added. I already taken the insult out, and there is a whatever stunning of myocardium, the echo is showing improvement. So it is not a purely scientific, very difficult to explain with one case. See, I cannot talk like an authority, that I have to put in the as a heading. So with all these things, we took it. So we all have to try, and we have to take more severe LV dysfunctions into our fold, and we have to work. Thanks.
Thank you, Gokhale.